Hello, I'm Dr. Stephen Bradley, anesthesiologist and U.S. Naval officer. I'm also the host and creator of the Black Doctors podcast. This podcast provides weekly 30-minute episodes that tell the stories of minority healthcare professionals. It is my hope that hearing these unique and inspiring stories will encourage others to consider pursuing these challenging and rewarding career paths. So please join me for the Black Doctors podcast, available on Apple Podcast, Spotify, and all major streaming platforms.
Honest questions with honest answers. This is Unfiltered, brought to you by the Emergency Medical Minute. Welcome back to another episode of Unfiltered. We're very fortunate to have Dr. Chris Hoyt with us today. Dr. Hoyt is an ER physician, toxicologist, and researcher based here in the beautiful city of Denver, Colorado. We've been fortunate enough to interview a list of distinguished and interesting folks, and Dr. Hoyt is absolutely no exception to that. So thank you so much for making time to come on the podcast.
I appreciate the invitation. Thank you. Happy to be here.
All right. So one of my most favorite parts of doing this podcast, maybe the most favorite part, is hearing folks' origin stories. I think our listeners get a lot of value out of hearing where folks come from and how their particular journey led them into medicine or emergency medicine, and in your case, toxicology. Would you mind just for a few minutes kind of sharing with us your background and how you got into medicine in the first place?
Yeah. So, I'm actually originally a Texan, big Dallas Cowboys fan. And I moved around a little bit, after I graduated from high school, through college, went to the East Coast and went out to the East Coast and went to college and decided, before my mom, she was an office manager, a radiology office manager at Southwestern at Parkland in Dallas. And so that was kind of my first sort of introduction into like, what do these people do? What do these physicians do all the time? And I would hear these stories from her. And my dad got sick. He got sick when I was young, around 12, 13. He had rheumatic fever as a child and ended up having to have an operation to repair one of his heart valves. So I got a really close up view into the world of medicine, being with him and going through that whole ordeal and watching him recover from that. So that's kind of where I decided, this is what I want to do, which is where, that's what kind of where I got the bug, decided that I wanted to be a physician. So I ended up going to medical school in New Jersey. And then I came back across the United States a little bit to Chicago, which is where I did my emergency medicine residency at the Cook County Hospital in Chicago. And at that time, I did my emergency medicine residency there. And I got, I had a very cool case there of a person who, it was actually a malicious case where someone tried to poison someone. And for some reason, I don't know what that says about me, but for some reason, I thought that was a really cool thing. And I thought, oh, wow, this is really interesting. And trying to do the detective work to figure out what had happened to this person, what the substance was, how to treat it, all that stuff really got me and made me have the bug for toxicology. Plus, my mentors in residency both were toxicologists, and they're still mentors of mine today, great friends. Two of the best people, Sean Bryant, and Steve Axe, two of the greatest people I know. And those are kind of really, they gave me the push to go into toxicology. And so here I am at Rocky Mountain Poison Center now. And I'm the medical director here. And I've loved toxicology since, and I would go back and do the same thing if I could.
What a testament. I thought you were going to say you wanted to be a cardiothoracic surgein after your dad's heart valves.
Right. Whoa, how did you make that leap? Yeah, no, I hear you. Actually, now that you say it, there was a time where I thought that cardiothoracic surgery was actually really cool. I still think it's very cool. When I was coming, when I actually first started medical school, I thought that maybe this is what I want to do. But then for some reason, I caught the emergency medicine bug and decided to do that.
Yep, I know the feeling,
You
and
know the
I think
feeling.
I do, and when you talk about toxicology, I think a lot of our listeners are residents and they've had some exposure to it. A lot of our listeners are pre-hospital folks and other folks, and what strikes me, and I'd love to hear your perspective on this, is like you said, the detective work of being a toxicologist. It is such a broad understanding of the chemistry of different exposures and different ingestions and different poisonings. It is such a broad knowledge base, and it really draws on a lot more basic science than our day-to-day clinical function as emergency physicians does. And tell me about how did that kind of drew you, whether it was the different classes of exposures or whether it was the detective work. I mean, I think it is a unique field, and one that I think is underexposed in a lot of ways, even through training in many ways. And I'd just love to hear kind of what about that drew you in initially.
Yeah, no, so I could not agree with you more. The way you described toxicology, one of my colleagues always describes toxicology as medical chemistry, because you're right. There's a lot of basic science pathophysiology that goes into it. What I love about it so much is that it's hard so toxicology. There's ongoing research all the time because we have to do this as much study as we can, because it's hard to do really good research in toxicology, because you can't poison someone and do a controlled trial poisoning someone. It's tough to do that. So there's tons of research that goes on, but the beauty is, like in emergency medicine, it's great because a lot of times we have limited information on patients and we have to make very rapid decisions to stabilize people and make diagnoses. What I love about toxicology is that a lot of the things that we do, we go through the pathophysiology to explain, why does this patient, why do they have the clinical manifestations that you observe? And why does this particular therapy work better than another one, based on what the pathophysiology is? And so there's tons of detective work. That's really what got me into it. It's like, oh, what are the possibilities? What could have done this and why? The research aspect of it is really cool. The chemistry and basic science of it, I love. So all those things together, like you described, are reasons why I have such a high affinity for this particular discipline. And
Absolutely.
And as you mentioned, it is toxicology is kind of pretty unknown in the world of medicine, like you said. There's a lot of people know toxicology, like toxicology reports and getting forensic toxicology in someone who's deceased. But then there's the medical toxicology piece, which is what we do, which is to try to treat people who've been poisoned.
Yep, absolutely. I mean, even within our specialty, the number of times I wound up calling you and your folks at Rocky Mountain for help, it is a niche field that is well more important than it is represented in many ways. And I think it's one of the things I'm most excited about having you on the podcast for is to give our listeners an exposure to that. I think one of the best ways to talk about toxicology are interesting cases. We could you've published on an incredible breadth of types of cases and research. I mean, whether it's black widow envenomation, other reptiles, amphibians, insects, you've published on exposures and ingestions. Would you mind kind of walking us through a couple of interesting cases that you think our listeners might want to hear about and learn a little bit from?
Absolutely. So I'll give you this one particular case that is kind of indicative. This is much more of a kind of a case of it was interesting because it was one of my first days as a toxicology fellow. So we Rocky Mountain Poison Center covers 4 big states. We cover Colorado, Nevada, Montana, and Hawaii. So it's like very disparate, and so one of the cases that I had when I was a fellow, we have an international program here as well where we train people that come from from other countries here to kind of refine their medical toxicology knowledge. And one of the cases came from one of our colleagues over in Asia, and there they've got 3 really bad snakes. So in America we have snakes that every once in a while you end up hearing about sad cases where people die, but in general our snakes are not as potent as the snakes, for example, in Africa or Australia or in Asia. And in Asia, in this one particular area, they have three types of snakes. They have a snake, the king cobra, which is a huge, big snake, and they deliver tons of venom when they bite. Probably the largest, one of the larger volumes of venom. Then there's what's called a banded krait, which is probably a snake that's has a potent neurotoxin that paralyzes you. And then there's the old world kind of pit vipers that cause a lot of local damage. And so there was a case where a kid was bitten in the arm by a snake that was there. And the problem is that the antivenoms there, instead of being all in one product, at that particular time, they were individual products. So there were three different antivenoms for those three different snakes. So person was bitten and brought in this young kid bitten on the arm. And the issue is that, the medical personnel there had to guess which snake was it. Because the kid was really sick, and so they didn't know which snake it was, so they had to guess which antivenom to give. And so they ended up giving antivenom. Some antivenom wasn't working, and what they recognized finally it was a king cobra bite. And what the king cobra bites do is they cause a lot of bleeding. One, and two, they cause some what we call with myocardial depression. So they cause hypotension and bradycardia, and that's usually how people die. So they were giving antivenom. They figured out it was a king cobra, so they started giving antivenom. But like I mentioned, the king cobra leaves such a huge depot of venom in whenever they bite their prey. There's a huge load of venom that goes into the tissue, and so they were giving antivenom. The victim would get better, but then hours later it would get worse again because the antivenom kept getting absorbed into the system. And so finally they ran out of antivenom, and so they called the local hospitals, and the local hospitals were sent over some antivenom, but the kid ran out. They eventually ran out. So they had called the Red Cross to get some antivenom there. And the Red Cross was able to find some antivenom from somewhere else. But it came to it that the kid was so sick, and they were worried that this kid was, going to die because of the effects of the venom. So the question came up is, should we disarticulate this kid's arm to get the arm off so that the venom would stop absorbing into the systemic circulation? So he was actually getting prepped to go to surgery, to have the conversation was had with the family, and poor kid, 18-year-old, his right arm dominant, was about to get his right arm disarticulated to stop the effect of the venom. And luckily, at the last minute, the Red Cross was able to find some more Cobra antivenom for him, and was gotten to this young kid. And he was given the antivenom, ended up not having to have that disarticulation. Had some scarring, obviously, on his arm from the bite, but ended up living. And so that was one of my first cases as a fellow when I was learning to become a medical toxicologist, that I will never forget that case, because I was thinking, first of all, it was like one of my first cases, my first days. And I thought, did I make the right choice here?
This is it's going to be like this all the time.
Yeah, exactly. Am I going to get these kind of cases all the time? And so, anyway, so that was a case that I'll never forget, is about this dude that we almost had to make the decision to amputate a kid's arm because of a king cobra bite. Another case that stands out for me is we had a case of an older man who he's in lives in a home with his wife, and he accidentally so one poison that's really bad is verapamil, which is a calcium channel blocker that we have some therapies, but they're not greatly proven. And if you get a sick verapamil case, you can do all the right things and the patient still may not do well. So when one of this particular person reached over, and the pill minders are not great. We in toxicology, we're not big fans of pill minders because they tend to confuse people at times. Well, he ended up taking his wife's verapamil, and he took and he's like in his mid 80s. He took his wife's verapamil accidentally, and he took multiple tablets of her verapamil. I think he took her week's supply of verapamil, and came in really, really ill. Hypotensive, bradycardic, was intubated. And in this particular case, we get to use what's called high dose insulin or hyperglycemic hyperinsulinemia euglycemic therapy. And so basically, like a diabetic dose of that is about diabetic dose of insulin for a person in DK is about 0.1 milligrams or 0.1 units of insulin per kilo. And we use about 1 unit of insulin per kilo. So we gave this man a 70, or I think it was maybe 75 kilos, 75 units of insulin as a bolus, and then put him on 75 units of insulin per hour to start. And we took him all the way up to 22 units of insulin per hour as a constant infusion. And what was amazing is, first of all, he lived. Second of all, his blood sugars were in the 400-500s. One of the effects of calcium channel blockers is that it stops the release of endogenous insulin from your pancreas, from the beta cells, the islet cells of your pancreas. So you have a relative reduction in this amount of circulating insulin. So these people become hyperglycemic usually. And his blood sugar went up to in the mid 400s. And despite the fact that he was on around 70, he started out on 70 units per kilo, 70 units of insulin per hour. His blood sugar didn't budge for days, stayed in the 400 or 500s, and then finally started to come down when he started to get better. The look on the faces of the nurses when we asked them to give the medication, was they're looking at me like, "Are you crazy? We're not going to do that." So a lot of times we actually have to go stand there with them to do it because they feel so very uncomfortable, which I totally understand. So I started doing this. But anyway, he came through, and I just remember thinking, did I really just give someone 70 units of insulin per hour after a bolus of insulin? Did we just do this to someone? And so that was actually really cool. And then the last case I'll talk about is we had a case of there was a plant in the metro Denver area, and like a mine, I should say. And one of the things that they use in the mines to kind of get out to try to remove metals from mines is cyanide. And so there was a big cyanide exposure because, so if you think about cyanide, in order to make cyanide, to not allow cyanide to become hydrogen cyanide gas, which is what we know will kill you, you have to make sure that it stays in an alkalemic environment or alkalotic environment. So pH is above 11 so that the gas won't disperse. Well, there was an accident, and somehow the storage of cyanide went from a pH of 12, 13, or somewhere high like that down to like 7, 6. And that's a big deal, and that releases a lot of hydrogen cyanide gas. And so we had there was a mass not a mass casualty, but I should say a sentinel event where there were multiple victims that came in who were cyanide poisoned. And you can imagine this basically shut our emergency department down because everyone was worried about off-gassing. And is everyone, are our providers all going to get sick? And so that case was really, I remember, interesting because we called in all hands on deck. A lot of our faculty and our fellows came in, and we had to treat a lot of these people with the antidote, which is hydroxycobalamin. And the patients all did well. There were no deaths, luckily, but we had a few people that got really, really sick from their cyanide exposure. So those are 3 cases that I think are pretty indicative of the kind of swath of things that we deal with as toxicologists.
Absolutely. Those are great representative cases. I mean, there's, like you said, there's environmental exposures, occupational exposures. There's, we didn't even talk about, plants and botany and that. And I think that's a great kind of representative sample of all the things you deal with. And to our discussion earlier, that's your world. You there isn't a compound that exists on Earth that people can't be exposed to or ingest intentionally or unintentionally. Yep. And I think what struck me particularly as you talked about the cyanide cases was your passage in the book Bring 'Em All, the ACEP book that our very own Don Stater was very involved in. And you talked a lot about the need for more awareness, more preparation regarding biological chemical weapons and and how we are in many ways unprepared for that type of a it's not a pandemic per se, but in this day and age, I think we talk a lot about preparation and things we prepare for well, and things that we maybe didn't prepare for as well. Could you touch on that because when you said all hands on deck, and you're trying to protect yourselves from off gassing, and you're taking on potentially a large volume of patients, a lot of that reminded me of your discussion of biological weapons. And could you talk about what a disaster like that would look like, and how we can prepare ourselves as a community for that?
Yeah, so that's actually a super important point and very timely with what's going on today. We so in speaking of biological weapons, there's always this it's when things are not happening, meaning that there's no biological threat popping up in the world. I feel like we do get complacent, thinking no, this is not going to happen. But around the world, things like VX gas and sarin gas, every once in a while these exposures happen, and those are really difficult to treat. And if you could imagine, like going to being here in Denver, going to Mile High Stadium, if there's a sporting event, there's 50, 60, 70,000 people, potentially in that stadium, or downtown Denver, if someone wanted to release some gas like that, you could kill a large number of people. And I'm just not sure that we're ready, that if it happened right 10 minutes from now, what the process is to make sure that everybody is safe, and where do we move people, and how do we mobilize resources like the antidotes that we would need. There's a particular antidote for gases like sarin and VX. Where are these stores located? Who's going to bring them to the site? Like, how do we keep track of the patients in the area? We've got people that are disaster planners, luckily, and they've got a lot of skill and a lot of experience doing this. But in the case of like a biological weapon like that, the coordination between my group and our disaster planners, and our state and local governments and all that, I'm not sure that we're really prepared to coordinate efficiently on the scale that we would need to if we got an attack like that. So, I think that this current SARS-CoV-2 COVID-19 situation should really be a wake-up call for not just the pandemic, but like you mentioned, like a biological an attack. If that happened, that would be, a terrible, and I'm not for sure that we're ready to attack that. So one of my goals is to I'm fortunate that my poison center has a fairly big reach, and I sit between three very large academic institutions with resources and some disaster preparedness. And so one of the things I would like to do when we kind of bring our attention back from COVID and get through this pandemic is to start to really plan for disaster preparedness on the level of scale that we need to for a biological attack, and get our hospitals ready, my poison center ready, state, local governments ready, and all that, so that we can meet that challenge when it happens.
That's right. I think I couldn't agree with you more. I think if there is a time in which the public and elected officials and others are going to have the momentum and the insight into preparing for this, it's now. Or I mean, in the short future, wherein we feel like we have a better handle on COVID, but there's still an appetite for preparation. As you know, and as you've seen over the course of your career, the oscillations of preparation, right? I mean, there's always a brief surge when Ebola becomes a threat, and then there's a brief surge, with things like SARS and MERS, and every once in a while, if there's an environmental exposure, there are these kind of waves of preparation, and then falling off, and then it's Newton's third law of everything, going to disorder from order, right? But I think in this unique pandemic, I think capitalizing on that is one of our best bets. Whether it's creating better infectious disease pandemic response mechanisms and apparatuses, or whether it's chemical warfare, biological warfare. I think this is the time to try and really beef up that infrastructure, right? Because I can't imagine a time in which the public has a bigger appetite for feeling more prepared for disasters like that.
Yep, you're 100% right. Couldn't agree with you more. This is the time to do it and put processes in place that stay in place and that are, maintained and updated and iterated to make sure that we're ready. Because it's going to happen at some point. It will happen. Who knows when? Can't see into the future, but I don't see a time when, I don't see how it would be possible that something like that would not happen.
That's right. That's right. Has COVID changed your job or your practice in any ways, either expected or unexpected? Whether it's having to talk to people about hydroxychloroquine, which 6 months ago was a drug that, maybe Chris, you frequently deal with malarial patients. It's not a huge portion of my patient population, but whether it's hydroxychloroquine or the new drugs or other ingestions, has COVID changed your practice in ways that you would have predicted or not predicted?
Yeah, so it's interesting. I just talked to someone about this recently. So, I'm with you. The number of malarial patients I've seen, like coming and presenting to the emergency department has not been very not numerous. So, what for poison center wise though, I think two major things have happened. Or actually, let me say three major things. 3 points about for effective COVID. One, it's interesting if you look epidemiologically at like big kind of crises and disasters, like Hurricane Katrina. And if you look at this particular SARS epidemic, and if you look at the Great Recession that happened recently, if you look at these big events, call volume to our poison center increases. And we think that part of the reason is that, people in those times were vulnerable. And so some of the, self-harm attempts from medications and things like that go up. And so that's one thing is our volume has increased since this COVID crisis has occurred, which is pretty predictable, because we've seen it before. The second thing, and talking about like chloroquine and hydroxychloroquine. So, some recommendations were made previously about potentially the benefit of, either one of those anti-malarials, chloroquine or hydroxychloroquine, to prevent or treat, COVID-19. And that we've seen an increase in the number of calls to our poison center about especially hydroxychloroquine. And it's both questions as well as exposures that happened where there was an adverse effect. So we've had both of those, like questions about hydroxychloroquine, the drug, and then questions from providers calling us to say, hey, this person overdosed on hydroxychloroquine. So both of those things have happened. In the case of chloroquine, there was that sad case of the gentleman in Arizona who took some chloroquine phosphate from an aquarium cleaner and tried to treat himself or prevent himself from getting COVID-19. He took that and ended up dying from that. And we also have had a couple of cases here of chloroquine overdoses, and they are really difficult to treat. Overdoses of those anti-malarials. Those are some of the drugs that we refer to as, the keep you up at night drugs. If the patient overdoses on that makes you worried because they're tough to treat. So we've had that. That's the second piece is that both of those drugs have popped up. And then the third thing is, this is the Swiss cheese effect that, number one, kids are at home more now because schools have been out. Number two, the recommendations are to clean all your surfaces. So sales of things from like Lysol, cleaners from Lysol and Clorox are up. And so exposures to bleach and other cleaners are up 20%. Year on year, if you look to February, March, April, year on year, they're up 20%. So we've been dealing with that very frequently. And I've put out a couple of press releases and things out about not drinking bleach because it can be very harmful, and you should not do that. There's no evidence that drinking bleach will help you with treating COVID. So we've had to do that. So those three big things have changed our practice. So to the point, we talk to our agents on phones. I've talked to my medical toxicology fellows, the learners. We talk to them about it. That we're getting calls about this, and so we're trying to educate the public about those things.
Absolutely. Thank you for that insight. many of the unintended consequences of quarantine, certainly, and
Yes.
your perspective on that is so helpful. Do you just have a better sense of what the numbers look like you said, you can compare it to year over year, and it's something that, as things slowly reopen, I think I'm hopeful to see a downtrending, but it's not going to be anytime soon. I mean, I think there's still that risk, and the risk of those exposures is going to continue to be present in the community. Thank you for the work you've done to bring awareness to that, and to promote that, on a wider scale.
Yeah.
Can you walk through kind of what it looks like when someone calls the Poison Center? How do calls get kind of shunted to one individual or another? How do you guys prioritize and strategize your responses? As great as you are and your fellows are, there are so few of you. This is an unabashed call for more toxicologists, people who are smarter than myself, who didn't labor through organic chemistry quite as much as maybe I did in undergrad, but you're a limited resource, right? And in times like this where call volumes are up, how do you guys manage that and kind of direct calls to the folks who can best answer them, but also protect your limited resource of yourselves?
Yeah. So, a very timely question. We actually just the operations team and I just had this discussion the other day because it's super, very important. So in general, we probably take as far as just people call out their pets too, but we take probably right over 100,000 to 100 to 120,000 calls every year, specifically about people being exposed, humans. We have that call volume is actually higher when you talk about just information calls, asking about a product, is it safe, those kind of questions, and then the pets getting into stuff. But just pure, like, I got exposed to this and now I'm worried, we get about 120,000 of those calls every year. And so it's a huge volume. We've got what are called spies. They're specialists in poisoning information. They're basically nurses and pharmacists who are there on the phone to answer, like a call comes in and someone's asking you a question about a case or a call or whatever it is, or an exposure. Those people answer the phones. So if I call the Poison Center because I was worried because I overdosed on something, or if I'm a physician in the hospital and I have a patient there and I'm going to call to get a consult, that's the first person that would answer the phone, is either one of our trained nurses, or our specially trained pharmacists. And then if those people can't really answer the question or the caller requests it, then they can ask to talk to one of our physicians, which, first they'll get a fellow, but we have an attending physician that backs up a fellow every single day, 24/7. So that's kind of how the call comes in. What you mentioned is a huge deal, that when you get these surges of phone calls, then it becomes difficult because, we had, for example, we had a mine tailing. There was a Alamosa River. There was arsenic that ended up flowing into the river for a bit from an old mine. And so we got a huge surge in call volume because people were super worried, and understandably so, about that, and wanted to talk about the terrible effects of arsenic. And so we, at that moment, we were the demand outstripped our capacity. So what we have done now is we've done a couple of things to try to mitigate that. One, we have what are called PIPs, which are poisoning information providers. So they're non-medical, but they can give information about products. So if you call and say, hey, how dangerous, or tell me more about this antihypertensive medication, what effects it can have on my body. There are scripts for those kind of things that people can call and get information on. So we kind of routed some of those calls out of the population of calls that go to our spies and our doctors. And so that's one way we've kind of left that resource more open to answer calls. We also have a chat service that people love to use, which is they can write into us, and then we'll have someone that's monitoring it all the time. They can answer that, those things through web chat, rather than tying up the phones. So we've done a couple of things to kind of offload our precious resource, which is if you get sick and you need to call us and you need some recommendations, then we have more capacity over the phones now, and our call times have gone down and all that good stuff because of it. So that's kind of one of the things we're doing. We're fortunate in Denver. We've got 26 now faculty. We have the going joke that we always have, true joke, is that we have more top medical toxicologists here in Denver than the any other city per capita in the world, which is true. Yeah, because like you said, you're right. There are only each year about 38 toxicology fellows in the country every year. And if you think about that compared to all those specialties, that's a tiny number of people that are replenishing the specialty. There are like 500, maybe 500, 600 medical toxicologists total in the United States. So not very many. And so we try very hard to offload that the phone service so that our docs and our nurses and pharmacists can answer calls coming in from people who, patients in the hospital that are sick, or, if you're a parent at home and your kid gets into something and you're worried, we need to take those calls right away to give people answers that they need.
Right. Well, and you're such a resource. And I can tell you from personal experiences that you're always available. Your folks, whether it's your nurses, your pharmacists, or your docs, have such incredible funds of knowledge, and they're approachable. And so the system that you have created is impressive, and we're certainly grateful for it, as I know ER docs across the country are.
Yeah.
One thing you had mentioned is that as COVID, settles into, a bit of a smolder as opposed to a full-blown fire, a lot of the things that had been on the back burner start to come back to the forefront. And one area in which you are heavily published and an expert on is cannabinoid exposures. And I think that the discourse regarding the legalization of marijuana has taken a back seat, as has everything during COVID. But I do think that eventually it will come back to the forefront as more states push to legalize it. And certainly here in Colorado, we were on the forefront of that wave. And we'll put in the show notes a number of citations but you've published on synthetic cannabinoid exposures, pediatric myocarditis, just overviews of the consequences of marijuana related cases and exposures. Could you share with us your perspective on marijuana and how it has evolved since legalization?
Yeah, absolutely. So, and you make a good point also about the fact that, COVID has taken up all our time, which it should right now. But yeah, this marijuana will come back around. You're 100% right about that. It's going to come back around. And so, what I would say is that the big thing about marijuana. So I was lucky that I got to. So Canada semi recently legalized marijuana as well. So I was lucky to do grand rounds in Ontario because they wanted to know the same thing. Like, what in the world is going on in Colorado, and how do we prepare for it? My feeling is, so from the Poison Center perspective, we get calls all the time about people who tried marijuana. They, in the beginning, people that smoke marijuana, very few people really get ill. With marijuana, they might end up in the emergency department because they, get a little too high and, not feeling great, have to go in. But really, like, as far as major outcomes, very, very few people. But then came edibles. And so if you think about an edible, like the concentration of THC, tetrahydrocannabinol, which is the psychoactive substance as part of the alkaloids in marijuana, the concentration of those in the edibles is very high. So once edibles were released on the market, we started getting more calls. And if you think about it, like the product, like if you're going to eat a brownie or a cookie, you're supposed to take a bite and wait for a significant amount of time while your body absorbs it. The problem is when you smoke marijuana, the effect comes on and off, and you can kind of titrate it yourself, right? So you smoke it. If you start to feel something, because the effect comes on pretty rapidly, and you stop smoking it and just let that effect happen. But with the cookie, when you eat it, it takes a time for the cookie to go into your gut, get absorbed, have first pass through your liver, and then go into your systemic circulation, and then to your brain where you'll feel the effect. That takes 30, 40 minutes to happen, 45 minutes to an hour to happen. So what will end up happening is people take a bite of the cookie and they say, all right, 10 minutes have gone by, 15 minutes have gone by, I don't feel anything. So they start eating more of it until they've eaten the whole cookie. And the whole cookie might have 100 milligrams or so of tetrahydrocannabinol, which is a high dose. So we started seeing more people come in an emergency department. and we started getting more calls to our poison center for these people who were sick from edibles. Plus the kids aspect of it, kids getting into edibles is a big deal because the little kids can get very sick from it. And we've had some kids that have gotten pretty sick from eating edibles. So my take is that, I don't, with this particular thing, if we're going to legalize marijuana, we just have to make sure we regulate it to make sure we keep the public safe, especially the kids. And if you look, one of my colleagues and I published a paper where we looked at poison center exposures. A huge number of the calls that we got were for kids in the 0 to 5 years range. Because kids in that range are they're explorative. They like to explore. They like to put things in their mouths. And so we got a huge number of calls. So that to me is the biggest public health message is edibles in young kids. One of my faculty colleagues, actually two of our faculty colleagues, went and lobbied the state government about the child-resistant packaging and changing the packaging so that it makes it harder for kids to get into it and make scoring the packaging so that, you don't just get one big old brownie. It's cut up into different pieces that are all scored and like almost like a blister pack so that, you can't just eat all of it at one time. And to hope and hopefully those things would sort of limit exposure. But I think that, if we're going to legalize marijuana and do that, we got to watch out for the edibles, especially, and watch it from the young kids because there are cases where these kids have gotten sick.
Absolutely. We touch on this topic from time to time across different platforms through the Emergency Medical Minute, and there's so many components to it. There's economic, there's social, there's health, there's medicinal components. But I think your perspective about the toxicologic consequences of overdose and exposures in kids there's no more important perspective. I appreciate all of the work you've done to publish on this, to spread the research that you've done on it. And like I said, we'll certainly link to those heavily cited papers in our show notes here, because I think your perspective is one that should carry a ton of weight as the discourse of this kind of continues, both here in Colorado and nationwide. So thank you for that. I appreciate that, Chris.
Thanks.
So I could talk to you all day. Truthfully,
Mm-hmm.
I have so many. There is no limit to the breadth or depth of toxicology, which is a kudos to you for tackling the field. Truthfully, a field that you'll never worry about reaching the end of the knowledge base, right? You'll never have to worry that you've run out of things to learn. It's a dynamic and changing environment as new compounds come on the market for a variety of purposes. Do you would you mind touching kind of as the last topic, just about what you see future challenges in the world of toxicology and kind of directions you see the field going in or concerns you have going forward? Would you mind giving us an insight into the future as best as you can tell?
Yeah. So one of the big challenges, so I'll tell you, one of the things I've been thinking about that I think in the world of toxicology we need to do is we need to catch up on the technological end. So, a lot of healthcare is going digital, the ability to do, remote patient monitoring, the ability to track things on social media so you have an idea of, if somebody's talking about a new exciting drug that they're abusing, it's not necessarily is it good or bad, but the knowledge, knowing that drug is out there earlier than, we're getting a lot of calls to our poison center, because by then, an epidemic may have spread.
That's right.
There's a case of one of the Opana, which is an opioid. People were abusing. We've had this huge opioid epidemic, but people finally figured out, because of calls to the poison center, that there was an HIV outbreak because of the way that people were crushing this up and using syringes in Indiana. And we didn't learn about that until, calls came into the poison center. And luckily we do surveillance and we picked, it was picked up. But getting ahead of the curve in toxicology, I think we need to take a look at that, to use digital technology that other industries and areas of healthcare are using to predict things, predictive analytics and big data. I would like to see our specialty kind of embrace that, to be perfectly honest with you. So web monitoring of social media, using big data and predictive analytics, things like that. Using artificial intelligence is another thing. to, like you mentioned before, to kind of offload the administrative burden for some poison centers. And then, also one of the other big issues in toxicology is, again, is our specialty is pretty small, but we just need to make sure that we're training enough doctors. Because I think you hit nail on the head earlier when you mentioned it's a small niche specialty. We just have to make sure we have enough people around to serve the needs of our local communities, to make sure that they have access to toxicologists pretty readily. Those are two of the big things I would say. So embracing technology for our specialty to do that, and then the medical education of toxicologists, to make sure that we are really rigorously training well the next generation of medical toxicologists. I think we do a good job of training them. It's just, I'd like to see our specialty expand and grow. We probably need to put more emphasis on, I don't want to say advertising the specialty, but really putting it out there so people know what it is. I think that's super important as well. So those are some of the challenges, I see with our specialty going forward, is that we're kind of, I think, a little bit behind technologically. I'd like to see us advertise the specialty a little bit more and make sure we're training enough medical toxicologists for the future to make sure that our specialty continues to grow.
Absolutely. It would be nice to get out ahead of the next Tide Pod challenge, wouldn't it?
That's exactly right.
Well, Chris, thank you for your time. I mean, we're so fortunate to have you here in our local community, and also, the country, as you said, all the states that you're active in, and internationally. You're such a valuable resource for us personally. Like I said, I've had numerous cases of overdoses and ingestions that I have myself and the patients that we're taking care of here have benefited from. And I know I speak for the hospitals across the area and hell across the country. So thank you so much for making the time. You are welcome back anytime. We'd love to have you. There will never be a shortage of new and interesting toxicology topics. Thank you. We really appreciate it.
Okay. Thank you so much for having me. I've enjoyed being here. Really appreciate the opportunity to come on.
We are on a quest to provide the world with free medical education. Please help us out by rating us on iTunes, following us on social media, and subscribing to our newsletter at emergencymedicalminute.com.